Good afternoon, everyone, and welcome to this webinar on the management of a scar following a C-section. So today we are delighted to be joined by Jenny Gillespie, who will be delivering a short presentation followed by a Q&A. So we do have some pre-submitted questions to get through, but if you are watching live, please feel free to put some questions into the Q&A section and we can get round to addressing those. So welcome, Jenny, and I will pass over to you for the presentation.
Hello, hi everyone. So a little bit about me to start with. I've been a chartered physiotherapist for just over 20 years, initially working in the musculoskeletal sector in the NHS and in private practice here in the UK and in the Middle East. My interest in pelvic health really developed after the birth of my 3 children, over 12 years ago now. When I started to combine my MSK skills and develop my pelvic health skills to really offer a holistic assessment and treatment of women of all ages. When I moved back from the Middle East, I set up my own practice, the Mummy Hub, which is based in Tunbridge Wells in Kent, where I see like a variety of women with pelvic floor issues. But I am quite passionate about postnatal rehab, which is sort of where the C-section recovery comes in. So today, I really wanted to do a quick whiz through how I would approach a C-section patient. So a lady coming in postnatally with a C-section scar. So a little bit about how I would assess them and then how I would treat them and how I have incorporated the LymphaTouch into that practice. So I'm aware probably some of the attendees here are other practitioners, other professionals. I'm sure there's some soft tissue therapists there, and you may sort of manage your patients differently, but this is your sort of pelvic health physio assessment. So the subjective is really important. I want to know that woman's birth story. I want to know, was this a planned elective procedure or was it an emergency C-section? There is, in my experience, a huge difference in the tissues in the body, in the scar following an emergency C-section versus a planned or elective procedure. And you think about what that mom that has had an emergency C-section has gone through, probably a really long drawn out labor, possibly induced, other intervention, maybe forceps, maybe, you know, they may have got as far as forceps. They are going to be exhausted. They're going to be dehydrated, they're going to be depleted, they may not have slept or eaten properly for 2-3 days. There's going to be an element of stress, fatigue, fear through that birth process. And you can really see that in the tissues postnatally. And following on from that, what are their feelings around birth? So have you got a mom there that really had her heart set on a drug-free vaginal delivery in water, and as it turns out, had an emergency C-section? Not always, but that can really have a bearing on how they interact with their scar and their feelings around their scar, and can really make a difference to your treatment. You need to really focus that in on any management with that scar. What's their postnatal recovery been like? Have they had pain? Did they have any infections in the scar? Was there any delayed healing? Did they need to go and get a stitch removed that hadn't dissolved? Are they still in pain? Has it healed? What has their activity levels been like? Have they got 3 other kids that they're running around after? Was their baby in special care? Were they, you know, in and out of hospital and sitting on hard chairs for weeks on end worrying about a baby? Or have they had quite a supportive, nurturing postnatal recovery where they've been able to rest and had good food and recovered well? And what is their support system like? Do they have a partner? Do they have family nearby? Have they got a cleaner? Or are they doing most of all of that themselves? We look at bladder, bowel and prolapse symptoms, and that gives us an idea about whether there is any other element of pelvic floor dysfunction going on. And pain, not just pain from the scar, but any ongoing pelvic pain, lower back pain, that's going to affect how that woman is moving and how she can access her rehab. And finally, sexual function. Are they having sex? Is she having sex? And is there any pain or discomfort with sex? Again, another indication that there's other pelvic floor dysfunction, other pelvic dysfunction going on. And then I want to see how she's moving. So we're going to, as we go through this presentation, talk a lot about fascia and an understanding of fascia when you're treating scars, I think is really important. And anyone that knows anything about fascia knows that the fascia runs all through the body in sort of long lines, and a C-section scar will interrupt those lines at the front of the body. So not only the one that runs all the way up the front of the body, but there are oblique lines that run across and round into the back, into the thoracolumbar fascia in the back. So lumbar and thoracic range of movement are really important, because a restriction in the scar can cause a restriction around into the back. I look at rib range of movement because the breath is very important, and to get a true good effective diaphragmatic breath you need good rib movement. And again, if there's a fascial restriction, that can affect the rib movement. We look at core or transverse abdominis activation. The transverse abdominis is not necessarily cut through in the C-section, but it is moved and it is affected and sort of switched off a bit by pain and swelling from the incision. So we want to make sure, not to mention stretching and postural changes in pregnancy, where this muscle sort of often is a little weaker postnatally in all women. So we want to make sure that that muscle is functioning correctly, because this is one of your sort of core support systems. We look at pelvic floor function. That is a whole nother talk, so we won't go into detail here. And then functional movements, so movements that the woman is doing all the time and needs to be able to do. Squatting, lunging, deadlifting. Can they do these movements? Is there a restriction anywhere in those movements? Could that be coming from the scar? Is it pulling? Is it from the back? Is it from the hip? Does it look like there's any muscle imbalance there? So we look very globally and very functionally. And then at the hip, a C-section scar sits very close to the hip and the hip fascia, and that can affect the alignment of the whole limb when you're squatting, when you're bending, when you're going up and down stairs. So we look at the hip and lower limb. And then I want to really look carefully at the abdominals and the scar. And I don't want to just do this lying down, because a scar particularly looks very different in standing and in sitting as it does in lying. And you can't always, if you're looking at a patient just lying down on the bed, you can't always see all the true restrictions of that scar. So I do a bit of both. And in standing, that's when you're really going to see any tethering, any pulling, and how it's affecting the woman functionally. We look at posture and alignment. Posture changes massively through pregnancy and can often be changed slightly after as well. So that's as a result of the pregnancy, but also as how that woman's using her body. Is she carrying the baby on one side? Does she always birth them on one shoulder? Does she have a preferred side for feeding? Is she carrying the toddler around as well? Are her shoulders up by her ears because she's really stressed? And what effect is that having on how she can breathe and how her abdominal muscles can function? How is she sitting? So with a C-section scar, we want some early movement in that scar. Unfortunately, by the nature of new motherhood, often sort of you're sat feeding in a, on the sofa in a chair, and that flexion is compressing that scar and not allowing it that lovely early movement. And so we talk a lot about building in some movement and position changes, and taking care with feeding position, particularly early on. Breath, again, is another huge area, but I see a lot of sort of more dysfunctional breathing postnatally. When you're pregnant, your diaphragm can get shunted up by the baby, particularly in the 3rd trimester, and so you're not getting that great rib expansion, and diaphragmatic breath will tend to be very apical breathing. Again, if you're tired and stressed, you'll default to this breathing up here. So we want to help a woman access that diaphragmatic breath. That's going to help with activation of the core and the pelvic floor, and restoring function there. But if there is a restriction from the scar, this can be difficult. So the breath is really important. Diastasis recti, again, a whole subject on its own. So this is separation of the rectus abdominis muscles towards the end of pregnancy. And really all I'm going to say about this here, because I don't have loads of time to go into this, is that in my experience, a tethered and stuck C-section scar can prevent a diastasis from closing. So it's good to know and to assess for that, to know whether it's part of the picture, and the sort of diastasis rehab and the scar rehab would then go along hand in hand, really. I'm looking at the abdominal area as a whole, in its abdominal appearance. So where's the umbilicus? Is it being pulled? Often you see it sort of being pulled to one side, and that can be the scar. It can be sort of visceral fascia tethering, excuse me. But it sort of gives you an idea that there might be something going on the side that it's pulling to. What are the obliques doing? Often they're doing a little bit too much. And if a woman is overusing obliques, they're a strong muscle group, that's going to affect how she can access that diaphragmatic breath. So can she release the upper abdominals to get that nice expansion at the lower ribs? And it's also going to affect how she can activate the core muscles. So if you're relying on your obliques, you don't get quite as effective lower abdominal activation. And then the skin condition. So if you're looking at lots of stretch marks or that crepey skin around the tummy button, then that's giving you an idea about what the connective tissue is like, and what sort of quality connective tissue is and the woman has got. So it gives you a little bit of clue there. And then looking at the scar particularly itself, has it healed? So is it still red, inflamed? Does it look infected? Can you see any stitches that haven't dissolved? That picture is a scar that I wouldn't start scar work on, and I wouldn't use the LymphaTouch on. That needs more time usually. If you do suspect it's infected, that needs to go back to the GP and they need some treatment on that before you can start working directly on that scar. What position is it? Is it quite high? Is it quite low? Does it extend further to one side than the other? Does it go up at the end? I mean, you see all sorts. Have they had more than one C-section, and have the scars, have they managed to line them up quite nicely? Or I have seen big differences. Also in your history, sometimes they say that, oh, the doctor said they took out quite a lot of scar tissue from the first C-section when they did my second one. So there can have been a little bit of fiddling around there as well. So you want to know all of that. That all gives you information about what the scar may be like. And then you're going to have a little bit of a feel of the scar and sort of see whether there's any tethering there. So you will have had a clue from in standing. And I've got some pictures on the next slide of scars that are pinned or tethered. And one of the things that I think bothers women the most is this overhang, this C-section overhang, the little pouch that they get, even the very slim mums, and they get really bothered about this. And this is because with all the layers that you cut through, the 7 layers that you cut through in a C-section, as they heal, they tend to heal internally, and there's that sort of the scar can get stuck down inside, and that pulls the tissue in, and the tummy sits over the top there, and you get this little pouch. You can see that beautifully in standing, and when you're lying, then you want to sort of just almost gently move the two sides, the above and below the scar together, the tissue together, and you'll see that the scar dips down, and you can see that it's stuck down and tethering down. And these are the scars that, in my opinion, or in my experience so far, the LymphaTouch is really good for, because if a scar is stuck down like this, you want to lift it up, and that improves that appearance of tethering, and it improves that appearance of a pinned scar. Actually, it's the scar after. This is the let's go that way. So here we go. These are two of my clients. You can see this first one here. The right side of her scar actually is looking, it's on the way, it's pretty good. There's a little bit of tether, a little bit of pinning here, but there's not a lot of pull. But this left side, there's quite an overhang. So she sort of looks, when she's standing up, at one side looks more pouchy than the other, so it's not even. And this lady has a bit more of a traditional overhang and pouch. So this, she was quite conscious when you're in a swimsuit or in your gym leggings, you can sort of see that bit of tummy, and it's not touchy slim lady, it's not tummy, it's tissue that's being pulled there. So these are these are sort of fairly standard C-section scars that I see. These are both around the 5-6 month postnatal mark, and this is commonly what I've been seeing and who I'm treating with the LymphaTouch. So just going back to this scar here, so one of your other things you want to observe is the type of healing that's gone on. So do you have a sort of nice faded, flat, white, pale scar, or do we have a hypertrophic scar? So a hypertrophic scar is where the body has basically laid down extra connective tissue, extra collagen to heal the scar, and you've got a bumpy, raised, red scar. It looks quite sore, but they're not always sore, but they're definitely thicker. First is a keloid scar, and this one here is a keloid scar, where the same things happen. There's a lot of extra tissue has been laid down to heal the scar, but it's actually gone outside the line of the scar. So you can see here that it's thicker than the line of the scar, whereas a hypertrophic scar is really just along the line of the scar. A hypertrophic scar does work well with scar work and the LymphaTouch, and I do treat these. And the gold standard for a keloid scar, for management of a keloid scar, is compression and administration of silicone. So I don't tend to treat directly on the scar. I would recommend the silicone products and compression, and see how we went from there. I don't see loads of these. I do see quite a few hypertrophic scars. Okay, so here we go. How does it feel? Firstly, really, this is another lady that I've got that is quite pinned in, very, very fit, very good abdominal function, but she's been left with this sort of pinned scar here. So yeah, how does the scar feel? Firstly, can the patient touch and look at the scar? So this is going to be important for your approach to scar work. If they can't touch or look at it, are they happy for you to? And do you need to go a little bit slower? Start off in the tummy rather than directly on the scar, start off around the back, or are they happy even though, and I do have this kind of, they won't touch and they won't look at it, but they're okay for you to do it. So that's a little bit different. Obviously, we find scar work itself can improve a patient's interaction with their scar and their ability to connect with their scar. So if you can get the tissues moving and the blood flowing and get it feeling a little bit more normal, they have a better reaction to it. But you need to know where they are with this. And sometimes you can just start with, like I say, either further away or just with some gentle work. And if you want to send a patient away doing self-scar massage, again, that might just start with them looking at it in a mirror or touching it with a face cloth or some cotton wool. So very sort of low interaction, and then gradually build that up. And is there any numbness or altered sensation? So this is really, really common to have some numbness where the nerve endings have been disrupted by the C-section. It can take quite a while to recover, but working on the scar, either manually or with the LymphaTouch, can really help this. And that, I think, if the sensation improves, really helps the woman reconnect with that area. I mentioned inflammation and tenderness. And pinning and tethering. Is that scar moving? So if you get in with some of your manual techniques and you're moving the scar, can you feel, is it moving? Can you lift the scar? Can you move it up and down? Is the restriction in the fascia above or below? Sometimes even into the mons pubis, you can get restrictions into the fascia as it attaches down onto the pubic symphysis. So look around the scar as well. And I always check the abdominal fascia. I do quite a lot of visceral mobilization and find that that goes really well with the scar work. Okay, so early management. So my moms that come in really early postnatal, or if I've got, ideally, if I've seen them antenatally, and I can give them all this information antenatally, but that doesn't happen very often. So early management for that optimal healing, hydration, diet. You want a protein-rich diet if they're not vegan or vegetarian, or the bone broths. As much protein as they can at every meal and in snacks, good quality fiber. So you're encouraging good gut health and good bowel movements, adequate rest, support with other children, running the household, people bringing in food, and with the baby as well. To encourage movement and to try and reduce the fear around moving after a C-section. Unfortunately, many women, certainly in my area, leave hospital with the minimum of information about what they can do to care for their scar and what they are able to do. And so they're worried about moving it, about delaying that healing. So we really want to educate around the need for gentle movement within what's comfortable, to get that early scar healing as optimal as possible. And some discussion around paced return to activity, so not obviously doing too much, all the normal stuff. A little bit about touching the scar as soon as it's healed over, and getting used to looking at it and touching it, so we're not getting the picture where somebody's sort of 4, 5, 6 months down the line and they're completely ignoring that area. And if the scar is healed and they're happy to do so, that they can start some gentle self-massage from 6 weeks. So then later, other scar, how to manage scar then later, with soft tissue work, myofascial release and scar release. So all those soft tissue techniques that you've got at your fingertips. There were quite a few questions, I think, before about products that I recommend and that I use. So I'd plan to cover that here. Scarban is the silicone treatment that I recommend. They do a C-section kit. This, I think, is the gold standard for silicone strips. It's sort of infused with the silicone. You can get silicone strips on Amazon for scars, but they are not the same product. So this is the one I recommend. For oils and creams, I mean, I think it's really important that you keep the abdominal tissue sort of hydrated and nurtured, and things like bio that they use in pregnancy can be really good. I really love this product from Naki. This is my little bottle that I use with my LymphaTouch. This is a skin optimizing oil. This works really nicely with the LymphaTouch for a treatment. And patients can use it at home as well. And there's a skin, I've forgotten what it's called, essence. There's one that's really good for healing early on as well. And they're very helpful with recommendations as well. And then Nessa Organics also do a really nice cream, but they've changed their name now, and again, I've forgotten what that one is. That's the other one that some of my clients have used, but I tend to recommend the Naki and the Scar Band for the silicone. And then the LymphaTouch, which is why we're all here. And so I've been using LymphaTouch with all my C-section scars since I got it. Since I got my device about 7 months ago. So prior to this, I was doing all my scar work manually, and being completely honest, the main driver for me looking for something else was I'm not getting any younger and my thumbs are starting to hurt. I thought, I love treating these clients. There's got to be something else out there that can help a little bit. So the LymphaTouch device is used negative pressure to mobilize the tissues and the fascial connections. It increases blood flow, it increases lymph flow. It softens the scar and it does improve the appearance of the scar tissue. So those hypertrophic scars, those raised scars, it really gets in there, gets them moving, gets the blood flowing into the scar, and does improve the appearance. This is where I see the huge difference. So it reduces that pinning and that overhang. So by basically sucking the tissue up into the cup, you're lifting that tissue that's pinned down. So whereas you can work on the surface and on the layers under the surface, you've really got to work to lift that tissue. This does it much, much easier and much quicker. So I definitely see quicker, more immediate results. You often see a difference with your manual techniques, but this is definitely quicker. It's very, very comfortable for the patient. Even in those early scars, you can start on quite a low setting and gradually work them up, and it's a comfortable sensation. It does improve sensation around the scar quite quickly. It really stimulates those nerve endings, and some of my ladies have had really good results with that, with sensation. It does work on older scars. I have a nearly 13-year-old C-section scar that I have started to use on, although I'm not as, we always do what we say, not what we do. I'm not as good at treating mine as often as I should be, but it has made a difference. And I have a few ladies that I've started to use that have got older scars, and it is working. It's a bit slower, as you would probably expect. So once you're past that sort of 2-year remodeling phase for a scar, I think it definitely doesn't give you as quick results, but it does give you those results. And it's very easy to use, and it's very portable. And so these are just a couple of the before and afters of those photos I showed you earlier. So what I've tried to do is give you, this is in one treatment for both of them. It's the same treatment. So this lady you can see here, you can see the difference, I think, in both sides actually, but particularly here you can see that you've brought the scar out a little bit more and leveled off this overhang a little bit. This lady in the middle, we've really opened up that scar. It's much, much flatter here. You can see a real difference from the overhang. She was delighted, actually. This was her first treatment. And it made a big difference here. And this lady, this is an older scar, and this is taking a little bit longer. But again, from here, where she's really sort of pinned in, that sort of smiley face type picture, and this has opened up the tissues a bit. But we've talked a lot with her that she's probably going to need to do perhaps a little bit more treatment with her. But you can see even after one treatment session, just the difference there, and that's really nice for getting a buy-in with your clients as well, I think, because everybody wants results, don't they? And I think certainly with physio, sometimes we have to sell them the exercise, the rehab program, the compliance with that. Whereas this is a really nice win for them. This is a really good for their buy-in, that, oh yeah, okay, I can really see a difference there, I can feel a difference, and they go away and they can feel that tissue is softer and is moving better. So it's really, really positive. just popped on the end there, just some other reading generally about scars. As with anything in this field, we're getting more and more research coming. So yeah, there's just some extra ones there, and that's it.
Amazing. Thank you so much, Jenny. That was great. And like I said, learning about all the considerations, especially for a particular C-section, it is very interesting. So as you said, I think you've done a really great job of answering quite a lot of pre-submitted questions, which is great. Obviously, we will go through some of the other questions. We did get a lot about the LymphaTouch, so we'll chat about that in a moment. Again, if you do have any questions, for those who are watching live, do pop them in the Q&A. And we'll visit those. I think there is a couple that have come through. Before we chat a little bit more about the LymphaTouch, we'll just revisit. We've got a question about assessment. So Andy has asked, do you look at breathing in functional assessment? So where, depth, rate, etc.
Yes, absolutely. So looking at somebody's breath is a huge part of any of my assessments, actually. So I'm looking at whether they can perform a diaphragmatic breath. So can they get that lower rib expansion? Can they release the abdominal muscles to do that? Have they got the rib movement to do that? Can they we look at breath rate and often slowing it down. I look at that in lying, I look at it in sitting, I look at it in standing. We do other breath techniques. I use the sniff, flop and drop technique sometimes to get that abdominal breath and sort of pelvic floor switching off. Sometimes I do some guided breath work with clients who are really struggling with letting go and with working that breath into their practice. So yeah, absolutely. And then when I'm looking at the functional movements like the squat and the lunge, and are they activating the pelvic floor and the core during that, breath is part of that as well.
Yeah. And with regards to as well as assessment, is it something that you would sort of teach some breath work for mums to go away and also do themselves, or obviously like future sort of treatment?
No, actually when I do my mummy MOT assessment, I think I send all of those women away with 5 minutes breath work a day before they go to bed. It's also really valuable for quieting down the central nervous system, that relaxation at the end of the day and trying to take some of the stress out of life. So I actually send pretty much all of my postnatal moms home with some breath work to do early on. I think if you don't get the breath right, it's really hard to get everything else right. So it's important to do it straight away.
Yeah. Great, no, that's great. Okay, so just another question that has come through with regards to compression. So obviously you mentioned about the silicone compression. The question is, do you know any more about research on compression garments before C-section? And that is with regards to the silicone. Is there any other sort of compression technique?
I don't know of any trials at the moment. I think from that, it's more with the silicone strips that they are compressive in their nature as well. So it's that treatment combined that they found. One of the references is a study that includes the treatment of hypertrophic scars and the use of compression and silicone and injections. That's on the last slide, but I don't know of any ongoing at the moment.
Yeah. Okay, lovely. And then lastly here then is a question about how long post-section would you consider scar treatment as an option? So you've mentioned your experience with, like I say, treating an older scar. Again, sort of 10 years. Again, is that at any point of an old scar that you would definitely try scar work as an option?
No, there's no limit. I think you always got to look at scars, actually. And so even if a woman was coming into me postmenopausally with pelvic floor dysfunction, and she had abdominal scars, I'd be looking at those scars because of those fascial connections, and we know how that's going to affect the fascia and the tissue into the pelvis and further into the spine and what have you. There isn't any limit. I think it's always worth having the conversation that it might take longer to change a scar that's older, but I think you've absolutely got to be looking at it.
Yeah, and quite interesting here is a comment of, for example, if a lady post-section, like say 10 years down the line, actually was having more back pain, pelvic pain or something like that as their number one issue, that actually could be still related to scar and fascial aspects rather than it being isolated to back pain. So like say revisiting a scar combination to potentially what is going on with another issue, for example, is again worth visiting and looking at.
Yeah, absolutely.
Okay, lovely. Okay, and then just a comment on the scar band silicone being sort of quite pricey. So is there any other alternatives out there, or do you not really know of any? Or
there are lots of alternatives. I recommend the scar bands from everything, all the research I've done.
Gold standard, yeah.
So there are cheaper alternatives. Like I say, they're available on Amazon and other retailers. I'm sure you can get them from pharmacies. They're just not as effective. So somebody could try that, but it's not really the gold standard. And I suppose you want to make sure you've got the right patient for them. So if they're going to be spending that money, is that the right scar? So if you've got somebody with a keloid scar, then it's probably worth them spending the money. But if not, maybe you try other things first.
Yeah, absolutely. It's down to a bit of a consideration, isn't it? And your clinical justification of sort of where you want to go with that. So lovely. Okay, so we'll just go to some of the pre-submitted questions that we got through. A little bit more surrounding on the LymphaTouch. So the question is, they would like to hear your opinion about LymphaTouch for abdominal hysterectomy scars. So have you been using it for other abdominal scars, or would you say your experience has definitely just been with C-sections?
I mainly use it with C-section scars because that is the majority. That's my main demographic of patients that I see. But I have used it on other scars. I've used it on some post-mastectomy scars, abdominal scars. Appendectomy scars can be really problematic. I've used them on those, and laparoscopic scars. It works on all scars, so you don't really need to differentiate between the type of scar. I've also got an older lady who sees me for a prolapse, who broke her ankle and had removal of metalwork and had a really stuck scar on her ankle that was affecting her gait pattern, which had made her prolapse worse. So I treated her ankle scar. So you can use it on any scars. You don't. This is sort of one example.
Yes, yeah, absolutely. Like I say, the LymphaTouch can be used on a range of scars, like you say, with regards to orthopedics, to anything so specific to a scar, absolutely. But the same principles apply to your clinical reasoning for treating the scar, at what stage and when. Again, that just falls into any similar scar work. So lovely. How much of a difference has a LymphaTouch made to your practice, and how does it help? So you did list quite a few of things that, like say, you found beneficial reasons of, like say, treating the scars, and one thing is saving your thumbs, which is always a great thing, isn't it? As a manual therapist, we need a little bit of a breather. So yes, would you say those are the main sort of aspects that you found?
I think I'm a sole practitioner. It's my own practice, so I sort of think quite carefully about investing in products and technology for the clinic, and so this was something I felt quite strongly about because I do see a lot of post C-section mums, so I knew that I do a lot of scar work and that I would use it quite a lot. So I use it with a lot of my clients. And I think that the main differences it had, I think it's definitely made my scar work more effective. I think it's made it quicker for patients to see results quicker. And I think, and it's definitely easier for me to use. It's less physical, and less on my hands. And then I also think, and I don't do this at the moment, but the potential from a business point of view for packaging this up is also there as well. So if you're looking at a business case, and selling packages of treatment, I think it sometimes we're very resistant to that in physio, but I think this works so reliably that you could do that as well. So it's made a big difference, actually.
Right, no, it's really good to hear. And I guess, the patient feedback as well, they enjoy the treatment, and do they enjoy sort of like they having a piece of technology as well incorporated into their recovery? I think patients quite like that as well, would you say?
Yeah, they do. They like having the treatment done to them. I think I do get very good feedback from it. I've not had anybody that says, "Oh, I don't like that," or "I can't stand that." Or I think that's the other good thing about it. There aren't many contraindications. I think, like you guys say, anything you would treat with your hands, you're okay to treat with a LymphaTouch, and so that means that it's really quite versatile. You can use it with most people, which means you can get used out of it. But yeah, the feedback is very good.
That's lovely. So we've just had a bit of a pop-up of a question. So from a business perspective, how do you market the use of LymphaTouch in clinic, or do you not consider it as a part, or do you consider it a part of a treatment toolbox? And obviously from a price point as well. So like I say, you mentioned that you've not massively gone into this too much, and from our perspective, and I was working with a lot of clinicians with the LymphaTouch, it varies of how clinicians will incorporate technology, whether it's LymphaTouch or something else, whether it's an adjunct to their existing service, or it has potential to be able to be an isolated treatment. So it can be very much down to sort of your demographic, your business sort of model, for example. So I think there's lots of considerations and how it best suits you, whether, again, the price of adding to your existing treatment price, or whether it's existing. Again, I think it all depends. Would you sort of agree as well on
Absolutely.
those?
I think it's very personal on how you run your business. At the moment, I use it as a part of the toolbox. So my patients get it as part of their treatment. I think you could, like I say, offer it as a sort of an assessment, 6 treatments, quick reassessment. But my feeling with that has always been that this would never be the only thing I would treat these patients with. So I think then you've got to be a little bit careful if they're only coming in for LymphaTouch, what are they not getting? And so we've got a lot of tools in our toolbox, and I think from a clinical point of view and responsibilities of the patient, they've got to have those other things as well. So you could potentially, if you maybe if you were looking, if it was just the scar that needed work and advice and what have you, or you could do possibly, I don't know, a scar package where they get other things as well, package it up that way. But I think it is quite personal. For me, I find it just works really well as part of my overall management.
Yeah, no, that's great, thank you. Okay, and then just lastly then, just a couple more. So how often do you treat the scar using LymphaTouch?
So again, that sort of depends on the scar, and the patient, and how often they can come in, and my availability. I tend to work because of all those things around once every couple of weeks, and I get carryover in that. With one lady that had got an older scar, we did try a bit more frequently, but she had the time to do that. But that's where I'm working at the moment, but that is also due to availability as well. I mean, I think you could treat every week, you could treat the scar every week. I probably wouldn't do any more than that, but I probably wouldn't do manual therapy any more than that. So
exactly. Yeah, so just to say, add on to that, so like I say, using LymphaTouch is classed as manual therapy, so it would fall in the lines of sort of the minimum time you would leave between manual therapy sort of session anyway. So like you say, you would always probably gap your treatment times of at least like a 3-day gap with any manual therapy, if you will. And then that would be the same principle for LymphaTouch. So like I say, but again, accessibility to patients and things like that is definitely probably a big one. But like I say, the differences that you can still make, even with the frequency or different frequencies of treatment that you get for a scar is still there, and it will still accelerate everything that you're trying to do, even with a varied frequency. Yeah, absolutely. So just a comment from Trudy. So thank you for the presentation, Jenny. So Trudy's had the LymphaTouch for 7 weeks, and she's had some amazing results with a range of scars, from recent scars to older scars. So that's a lovely comment. Thank you, Trudy. I think then the last question. When is it safe to commence abdominal training post C-section? That's the sort of last one we've got there on the list. So.
We lost you.
Can you hear me? Hello?
Hello, it went blank there.
Are we back?
I'm back.
Perfect.
I'm losing you.
Yeah. Can you still hear me now?
I think that was about the abdominal training after a C-section. Is that right?
Yes, that's right.
Can I continue?
Yes.
Can you hear me?
Yes, I've got you.
Yeah, so I start, I see the earliest I would see someone is around 6 weeks postnatally. Some of the C-sections it's a little bit longer, because I think 6 weeks can be a little bit early. And in that session, in that mummy MOT session, we do look at core activation, and most women go home with some sort of very early core exercises. So very basic, just activating the TVA, some things in 4-point kneeling, some bridges, and then we build up from there. So I think when you're looking at with anything, but if you look at core work, it's a continuum, isn't it? So you need to start by making sure you've got those basic building blocks there. So can they breathe? Can they activate their transversus? Can they activate their pelvic floor? Can they do all of those together? Can they do it in lying? Can they do it in sitting? Can they do it in standing? And then you add on movement, and you build on from there as the patient can tolerate that, and everybody's at a different stage with that. So you obviously don't want people doing loads of crunches and loads of planks very early until they've got that awareness. So yes, I do start as early as possible, but it's very controlled, and making sure they're activating the correct ones, and then we build on from there, and as quickly as possible make it functional. So it means to the woman, so they're not lying down all the time for their exercises, that they can get up and do a squat and make it functional.
Lovely. No, I think that was really useful. Thank you. So I think we've got through all the questions. So thank you so much for all your pre-submitted questions. Live questions have come through. It's been great. I definitely learned a lot. So thanks, Jenny. But yeah, thank you everyone for joining us this afternoon. Like I say, we hope you enjoyed the session. Thanks again, Jenny, for your time, your expertise in this area. It's so great to just hear sort of user experience. Obviously, I think it's very, very useful for clinicians just to hear and cross-reference for people's experiences and what everyone else is doing. I think it is valuable. So thank you. Following this then, everyone will receive a bit of a survey along with the link to the webinar recording. So we would appreciate any feedback and suggestions for future webinars as well. You can also visit the PhysiQuip Academy site, where you can find all our past webinars or other educational resources, so head over to that platform as well. So thank you again, Jenny, and otherwise I'll leave you and have a good rest of the day.
Thank you.
Thank you, bye.